So hi, good afternoon, good evening, good morning, very early morning. I'm on a limited connection here. Sorry. So thanks everybody for joining today. So this is part one of a two-part series. So as I think we've kind of gotten the hang of doing these two-part series at least. So we've been looking at the different components of integrated outbreak analytics and like the different data pieces and what that looks like, and all the different kinds of data and methods that we use to collect the data, and how all of them can contribute to better and more holistic understanding of outbreaks or public health dynamics. And one of the things that has come up, and it's interesting because it's actually brought up quite a lot of debate on like what it means and how we use it, is the tracking of events over time, and how do we use that for a better understanding of outbreak dynamics or public health emergencies, and also how we use that really for public health emergency and outbreak programming. So we kind of have, today we have somebody from the Integrated Analytics Cell, Izzy, speaking from the GRC, and we have, is it just Aaron speaking, or Aaron and Steph speaking? I missed that last email, but Aaron and Steph speaking from CDC Africa, who've worked on the PERC results to save lives surveys on COVID. And so these practical field applications of using the timelines. And next week we'll have a follow-up call looking a little bit more on interrupted time series and how we can use those really in modeling. And I'll let Ruby at the end plug a little bit more into that. So without further discussion, Izzy, I'm going to.
Okay, Simone's frozen, but I'm going to assume she just threw me into start. So
yeah, I think that's what she did. Yeah. Go ahead, Izzy.
Okay. I'm going to try and do presenter view. I don't know if that is okay. Can everyone see the screen? Normal view or presenter view?
Presenter view. You're looking good.
Okay, wait. So you can't? Can you see my notes on the side?
Nope.
No. You can't. Okay, great. Okay, yeah. So as per Simone's introduction, my name is Izzy. I work in the DRC with the Integrated Analytics Cell, and I'm sure that you're all fairly aware of what we do here. But essentially, it's operational research to support operational integrated analytics to support response actors to various public health emergencies, and there are very many of them here. So so this presentation, very brief, will be looking at the how for our research, during our analyses, we map, so we record and map different events or things that are happening just in and around the DRC to look at how they might impact what we're seeing in data. So when we refer to an event, we're looking at various different things. So it could be political things. So for example, there are elections coming up, or treaties between countries, or at the moment, for example, in North Kivu in the east of the DRC, there's an état de siège, a kind of martial law. We then might be looking at larger scale interventions that might relate directly to an emergency response. So COVID was a very big example for this. Things like border closures, movement restrictions, introduction of mask wearing, and then not directly related to COVID, but things like providing free primary education, and how that's a government intervention, but how that might have impacted communities. Then smaller scales are looking at interventions of response actors, so different activities that different organizations might be implementing. Economic events, so changes in food prices, changing in other prices that might impact how people can buy and sell. And then environmental events, so for example, natural disasters, so if there's flooding after excessive rainfall, or fires, for example, And then we have conflict, which again is particularly pertinent for this part of the world, but this particular part of the country. So I'm speaking out of Goma. At the moment, actually, there's increasing degree of fighting in the province, which remains to be seen how that will impact the population and the public health situation. But in general, why are events and timelines important? So essentially, they're things which can result in reactive behaviour of populations, which can impact their exposure to public health risk factors, or in general, community healthcare seeking. And then again, to the point relevant to the smaller scale interventions, they're also useful. It's also useful to look at events and how they impact health seeking behaviour as a measure of the impact of particular interventions. So an example here is COVID-19 in Goma. So we were researching the broader impacts of the outbreak rather than the disease itself. I've realized I'm lacking a graph here which shows this increase in cases, but just trust me that there was a spike just around June 2021 in Goma, which wasn't seen to the same degree in other parts of the country. Anyway, so we saw this spike in the data and we thought, okay, what's causing this? Why now? Why here and why now? So then on the 23rd of May, Mount Nyiragongo, so the volcano just on the outskirts of Goma, erupted almost exactly a year ago, resulting in population displacement, so people coming from the area to Goma, to other parts of the country, then a lot of movement across the border to Rwanda. Generally, in those kinds of circumstances, it's very difficult to adhere to public health and social measures, and also it becomes very low on the priority list of people. And then, yeah, a lot of people living in camps. The number of people in households increased because many have found themselves hosting displaced people. So again, we can never say that the volcano and the subsequent behaviors that people adopted was a cause of an increase in COVID cases, but we could possibly say it's correlated. And just to show here as well, so this is the data where we saw this increase in COVID cases was shared roughly around the same time as we were beginning research, generally into the broader impacts of the eruption, actually. So looking at the event and kind of working from there. So just some examples here of some DHIS2 data from Nyiragongo, the health zone. And so we've specifically highlighted the event there, so the volcanic eruption around May. And on the left, you've got the number of, just an example, it's a number of rapid diagnostic tests for malaria given, starting from volcanic eruption. So assuming that people will be tested at health structures if they show symptoms. And on the right-hand side, you've got the number of positive RDTs in Nyiragongo. So you can see that the number of positive diagnosed cases is considerably lower. So then we were asking that question, okay, well, if it's not malaria, then could this be something else? Could this actually be COVID because of the similar symptoms? And if so, is this increase directly related to the date of the eruption, or is it just coincidence? So what we do here as well, then, so we have our research teams in the field, and during a large part of this particular research we were doing was qualitative as well. So we then sent our teams out to try to understand whether these hypotheses, so whether the impact of this event really was one of the impacts was possibly an increase in COVID cases. So during that, we understand that there are no tests available for COVID in the zone, so possibly there are cases not being diagnosed. So maybe the impact was far greater than recorded. General disbelief in the existence of COVID, and it's in that part of Goma, it's very much not a priority. We also found that there was an increase in reported community deaths, or people reported increased community death, which they attribute directly to the volcano, but actually maybe this could be COVID as well. but then generally also just being in from the qualitative research, from understanding how people were living and how they were, they still are sort of surviving in the conditions post eruption, very much predispose the transmission of infectious diseases such as COVID. So just another example here is looking at diarrhea cases on the left. So you can see from the eruption an increase in diarrhea cases. Again, we found this data when we were looking at working backwards from the event itself rather than looking at diarrhea, but just to emphasize the use of the timeline. And then on the right hand side, this is data that we collected ourselves from health structures, which showed the same thing. So from May, this increase in cases. So just another example here is looking at ongoing research at the moment is looking at the causes of malnutrition in Tanganyika province. So one of the known determinants of malnutrition is household size, so particularly the number of children a woman has. I say known, so it's known from global research, but also one of the factors that we've identified here. So this is the DHIS2 data from Kabalo, which is one of the health zones where we've been focusing the research. So comparing Kabalo to the provincial and the national averages. And I've marked out their COVID-19 response at the date of or roughly when that started in Congo, so around March 2020. And then also mid-2021, there was the beginning of some healthcare worker strikes. So yeah, generally from the graph, there's a considerably lower engagement so it's contraception use in Kabalo versus Tanganyika and national. So contraception use in Tanganyika is anyway much lower than the national average, and especially since the end of mid to late 2019. And in Kabalo itself, it's particularly low. So particularly low engagement. So we, again, through our quantitative data and qualitative also knowledge and awareness of contraception is very limited as well. But we then, from the graph, so the first thing we'll do is, and almost systematically every month or every time we receive DHIS2 data, is to look at the trends. And before we plot the events, we say, okay, well, there is something we see here. So for example, from mid-2019, there's a big decrease in uptake of contraception in Kabalo and in Tanganyika as a whole. So what is causing this? And then we plot what we know. So here again, it's ongoing research. So currently looking into the events which might cause the things we see. But what could have been the impact of COVID? What could have been the impact of the healthcare worker strikes? For example, we know that during COVID nationally, there were decreases in uptake in contraception. Was this reflected in Kabalo as well? During healthcare worker strikes, maybe that impacted the people's willingness to come to healthcare facilities. Some facilities were closed, others were providing minimum service. Very few of them in certain areas were reporting. So again, we can never say that one thing is directly a result of the other, but at least it could be. And then I've just added a point there that mid 2019, roughly around the time, there's one quite well-known NGO and very local NGO, but it does work around family planning, which had been working in Kabalo and they left. So again, this could be they stopped focusing on the area, so it could have been linked to this decrease in uptake of contraception. Just a couple of examples here of other ways that we have plotted different events. So this is an example of cholera in North Kivu. So from the beginning of 2021 to the end of 2021. So we've just plotted the number of cases against particular things which might have an impact. They may not, but they might. So far left is mentioning, sorry, it's in French, the reopening of the schools following the second wave of COVID. We don't know if that will impact not cholera cases in North Kivu, but it could. So we have that noted there. What we've also got here is is the dates of our own data collection. So we have a household survey that we conduct systematically in North Kivu, and so we noted this here because it allows us to monitor whether there might be a particular event that might impact what we're seeing in the field during the data collection. So and then, for example, how communities might be reacting, how accessible a certain area or population might be. So, for example, if we wanted to do research with healthcare workers, but it was during a period of strikes, then the facilities might be closed, they might not be reporting. We found frequently that in Tanganyika, that the office of the ITE, the sort of head, the manager of the health structure, often would be closed even if the structure was open, so we couldn't see the registers. So that kind of thing we need to factor in, and it can impact the results we get after our data collection and subsequent analysis. Just another example here is this was provided by MSF, who we're working with in Kasai province. So this is just having plotted the number of survivors of sexual violence who come to their health structures against their various interventions relating to improving access to care for survivors so that they arrive within 72 hours. So again, we can't say exactly that when there are messages on the radio or theatre pieces, for example, that are started more regularly in the community, that can directly be a cause and a reason why more people come to health structures within 72 hours, but it could be. So at least being able to plot it allows them, because we do this and then we feed back to them, to say, okay, well, maybe this suggests that this intervention is actually impactful, or maybe it isn't. Maybe it's going to have the adverse effect, in which case reflect and try to recommend how there are different ways to improve it. So just examples of how we are collecting, just very basic, in fact, ways of collecting information about different events in the field. So, for example, just standard internet searches is an easy one. So, and it's quite quick. So if we see, for example, a spike in the number of cases of a certain disease or something, then we can look at the date and then do some web searches of what happened on this particular date. Was there something in this area that might have led to that? Then, so qualitative research, as I said before, so interviews, focus groups, we get the community to tell us. Then there's things like lots of local and national official communications that will be released fairly frequently here, and sometimes there can be useful information included in those. Using our local contacts and networks, so different if we cluster meetings or meetings with other organizations and discussing with them what they're currently doing and what they have planned. And then also there's a lot of information that gets passed around on social media, but we have to really be careful with that, because a lot of it well, needs to be verified anyway. So just lastly here, looking at recording events. So we don't actually have a very good system for doing this yet, so it'd be great if anyone has some suggestions. We were for a while, especially around COVID, plotting or tracking the events on a Google sheet, which was shared with various people in the team, with the idea that if somebody was aware of something happening in a particular area, that they would then put it into the table with the date, with the corresponding date. So it's something that I would like for us to actually get going again, but need to find a more effective way of doing it, because then it's, is it the kind of thing that we would have one person dedicated to managing it, or would it be multiple people? What's the most effective? How do we select which events are important to include as well? How do we know if something might be relevant? Do we just plot them straight into the epi curve or the graphs that we have showing numbers of cases, etc.? And then how do we ensure it's systematic, so the recording of events? Okay, that's me. I think I spoke quite quickly in a short space of time, but if you have any questions, please let me know. Thank you very much for the opportunity.
Thanks, Izzy. I think we might have lost Simone. excellent presentation. We'll open the floor for questions. Please use your reactions buttons at the bottom of your screen to raise your hands. And we'll start off with Raquel, if that's all right, with your question in the, or your comment in the chat.
Yeah, happy to read over or to explain. So I was very interested in seeing the different methodologies and say hi, the different methodologies and how you were gathering information.
Raquel, we can't hear you very well. Can you turn up the volume or go closer to your microphone?
Yes, if you give me a minute, I will go and get my headset. Feel free to start with someone else and then I can speak. Does that sound
okay
good?
Okay, great, thanks. I'm just looking around for questions. Simone, are you back online now?
I think so. Yeah, no, I
Yeah.
just also want to echo great presentation, Izzy. And yeah, I think one of the things that has been challenging as well has also been getting our teams to consistently remember to then go, oh no, you know, do you remember, did you collect the data of events, or did you write it down, or did you think about why that might be? Everybody remembers the healthcare worker strike, but and how that might affect like DHS2 entry, but somehow also things of what that means for behavior and willingness to seek care if there's no healthcare worker. That kind of gets forgotten. So also looking at all those different factors and how they actually influence multiple aspects of either data collection or health behavior or health outcomes. Yeah, so hopefully Raquel will come back, and I'm seeing the link, so I'm going to Google it right now. I see your hand as well.
Yeah, just to second what Simone just said. One of the things as well we have, I've got a bit of trouble with in the field with the local teams, is that they're local researchers who are very much from, you know, they're from the communities where we're working, and so to get them to systematically tell us about things that are happening, which for us during the analysis, you know, is like, oh, that could be a thing of importance, that could link to this, that could link to that, but for them it's just, oh yeah, well of course there's healthcare workers' rights, or of course there's this, of course this thing is happening, because it's just part of kind of a lot of the team's sort of everyday life, and they trying to get them to really make the connection between the analysis we're trying to do at the same time. Can be quite challenging, but yeah, so again, suggestions would be great.
I think I don't see any of the hands, so I was just wondering, Izzy, I might have missed this, but do you try and triangulate with events by speaking to the communities and asking if their behaviour or the particular event has affected their access to healthcare or their behaviour, etc., etc.?
Yeah, so to that, I'd probably say I mentioned qualitative research. So what we do more now is, so there was a tendency a while ago that we would be kind of either qualitative or quantitative, and then with the very welcome push towards integrated outbreak analytics, it's now kind of, you don't do one or the other, you know. So if we have something in quantitative data, if we see a trend or something that we need, a question we need to answer, that's when qualitative data comes in, qualitative research. So then it's going to the communities. We start with the teams, you know, because again, if they're from the communities themselves, so then asking their opinions, saying, what do you think about this? And then it's usually quite exploratory qualitative research to try to understand the particular impact. So actually the research around the volcanic eruption, this was a few months after the eruption that we did, but it was after we'd seen the spike in cases of COVID. So it's like, okay, well, maybe the eruption is linked to the COVID, but also it's probably linked to a lot of other things. So let's go and find out from communities how the volcano itself has impacted them. So to answer your question in a very long-winded way, I'd say qualitative research is probably the most effective way that we use.
Great, thanks, Izzy. So we have questions from Raisa and then Raquel, and then we'll move to the next presentation. Thanks, Raisa.
Yes, hi. I think Izzy, I understand very well when you say that the teams, they don't necessarily will record or recall that this event might be really important for the analysis. I don't know how the structure of your team is, and we did have and face the same thing where we were using the community perception tracker. What I find sometimes useful is really to work with the team who are collecting the information to also understand what we're doing with the information. So some of them, and I know we worked with partners for that, we actually included them into some of the analysis and discussion we were having. And the more they were getting to see what we're doing with the data and where we're coming from, I think the more they were a little bit more cautious about other event. I'm not saying it's perfect, but it's just, it was helpful. And I could see that in other countries where they were not necessarily integrated or part of trainings or part of some sessions, it was always very difficult. So I don't know if there's a way you can try that, but more, for me, the more the people understand what we're doing, what we're looking after, what we want to use, showcase, etc., the more they might be also looking for it.
Yeah, no, that's a really good point, and it's something that I think Simone just mentioned in the chat as well. So yeah, we really make a point of including our teams in the analysis, the results presentation, and the co-development of the actions that we develop with actors based on the evidence. But I mean, case in point, I was in Tanganyika last week and with some researchers that we recruited from Kabalo, which is a very small village in rural Tanganyika, and they were well qualified, and then they had experience in conducting surveys. But they had said, so we use them, we've been working with them for quantitative and qualitative research there. But one of the things they said at the end was that they were really, they just really appreciated how much of an effort we were making with them to really get them involved in more than just going out with a tablet and asking yes and no questions, which is what they've been used to. Because it's not just because they made it sound like they really appreciated it. But for us as well, it's also because we have, we heavily value, of course, their input, because they're the ones who are doing the work that we just oversee. And so the first thing we'll do is validate the results with them. So before we start presenting this evidence on malnutrition, salmon's malnutrition, it will require going back to Kabalo, sharing it with the team, and saying, what do you think? Because it's a reflection of the work you were doing. Because again, the more involved they feel, then the more likely, as you say, the more likely they are to volunteer information, kind of go the extra mile. They have an understanding of what we're really looking for, and then how them as individuals and as a team can contribute to that. Then that makes things just a whole lot easier.
Right, and final comment by Raquel before we move to the next presentation.
Thank you, and I hope you can hear me better now. Thank you very much. And Izzy, that was very impressive. It's fantastic and fascinating to see all this work that is coming through and how it evolves. My comment was around, you presented in, I think it was the slide before last, the different methods in how that you were using to gather information in the field. And I just wanted to maybe bring to your attention that there is an initiative that is the EIOS initiative. You can see it here, Epidemic Intelligence from Open Sources Initiative. UNICEF is part of it since 2011 and has a EIOS community, which means a space for UNICEF to use the system. The system allows you to go through open sources like news aggregators, over 35,000 different sources that are coming through every few minutes, and also social media, Twitter and Facebook. And it can be helpful to monitor specific events in the field or for long-term monitoring of any outstanding surveillance need. So yeah, just saying that maybe this is something you can explore and consider using. UNICEF has a community, and there are a number of individuals authorized. More individuals can be authorized to use it. So yes, a small suggestion, and thank you again.
That sounds amazing. Thank you very much. I will definitely. In fact, is there a link, or can we just access it?
So there is. I can send you a link to the webpage to have access to the system, and your UNICEF community manager will need to give you access. So I'm gonna do something. I'm gonna share here the link to the webpage so you can get further, like have a look at further information, and also our email address. And that way I can link you with the UNICEF community manager. So if they approve your access, which I'm sure they will, yeah, you will have access immediately, and we can register you immediately.
Perfect. Thank you very much.
Great, thanks again, and thanks for the great discussion. So next presentation, Erin, are you all set? Or Steph?
Yeah.
I'm not sure who will start.
Yeah, I'll go first. Thanks. Give me just a second to share screen. Is my screen being shared now? The audio coming through?
All good, perfect.
Awesome.
Thanks.
All right. Well, thanks so much for having us today, giving us the opportunity to talk about a project we've been working on for, gosh, about a year now. So the presentation is titled Using Timelines to Find the Balance of PHSM's Public Health and Social Measures for COVID-19. And my name is Erin Bochner. I work for an NGO called Resolve to Save Lives, and I'm going to be giving the first half of this presentation, and then I'll hand it over to my colleague Steph Sawyer, who's at Africa CDC, who will give the second half of the presentation. I'll be more focused on kind of the background information and how we created a graphic looking at several timelines, trying to link them together. And Steph will talk a bit more about how we're using the data as Africa CDC has been trying to use the visualizations to inform decision making. So this project that I'll be speaking about was developed by a consortium of partners called PERC, which stands for the Partnership for Evidence-Based Response to COVID-19. So this was a partnership that was created in response to the COVID-19 pandemic, and the main objective of this collaboration is to support evidence-based measures to reduce the impact of COVID-19 on African Union member states. And you can see the consortium members' logos at the bottom half of the screen. So one of the main products of this PERC partnership has been what we've named the COVID-19 Africa Hotspot Dashboard. And this is a dashboard that was designed primarily for internal use by PERC partners, though it is actually publicly accessible. And at the bottom of the screen, you'll see the URL africacdccovid.org. The dashboard has a few objectives to identify countries with growing or widespread outbreaks of COVID-19, to identify countries where a review of data and outbreak status is warranted, to identify where technical support around COVID-19 may be beneficial, really trying to help us and Africa CDC specifically to track the COVID-19 outbreak across the continent. And I could give a long presentation about the dashboard, but what we're going to do is zero in on one of the visualizations that's included on the dashboard. So as part of the dashboard, there are country-specific pages for every African Union member state. And for each of their states, we have this visualization, and I'll walk you all through it now. So the top portion of this visualization shows the trend in COVID-19 incidence as the blue line going across the screen over time. And then you'll see on this top visualization up and down arrows. So these up arrows indicate when PHSMs were tightened, and these down arrows indicate when PHSMs were loosened. And if you click on any one of these arrows, you can pull up specific information about what occurred on that date. We broke these PHSMs actually are already divided into categories. You can see in this example, it's adapt or close schools. Then you see a narrative describing what happened on that date. And then there's actually references so that you can see the primary data source that was used to categorize this PHSM. One thing that can be a little misleading about this top graph is that a single up or down arrow is a day when PHSMs were modified, but it could be that a single type of PHSM was changed, or it could be that a whole suite of PHSMs were announced. So this next visualization, which is essentially a heat map, is showing the PHSM stringency index. This is a index that was created by the group that maintains this PHSM data set. I'll talk a bit more about that on the next slide. But it gives kind of an overall, a single view of the strictness of PHSMs at any one time in a country. And then this bottom portion of the visualization looks at community mobilization data taken from Google. So did the PHSMs impact how mobile the population in the country has been? So you can see, if you look at the start of the pandemic, a whole bunch of PHSMs were announced. The PHSM index goes from a light to a dark color, indicating that overall stringency went from low to high. And then you can see how mobility, which at the baseline time point was obviously at 0%, how it dropped to around 70% of what it was initially before the PHSMs were introduced. So this one visualization can give you a sense of incidence, PHSMs, and then the impact on mobility. And I think being able to look at all of those in a single visualization has proven to be pretty powerful and useful. I'll talk about data sources, and then I'm going to hand it over to Steph after this slide. So the data sources for the visualizations come from 3 different data sources, and really the reason we're able to make this, what I think is pretty great visualization, is because we have these really great data sources that are available to us. We have EpiData, which is from official African Union member state reports, and Africa CDC maintains a database where they pull that information and enter it into that database on a daily basis. The PHSM data comes from the Oxford COVID-19 Government Response Tracker. And again, this is a data set they maintain on a daily basis. And then the mobility data comes from Google Community Mobility Reports, again, which is updated daily. And we use a combination of R scripts and custom JavaScript to pull and transform the data to generate visualizations using chart.js, which is a visualization library to create the actual visualizations. And then the dashboard refreshes every 2 hours to visualize the latest information that's available. And with that, I'll hand it over to Steph to go through the second half of the presentation.
Thanks, Aaron. Hopefully you guys can hear me okay.
Yep, you're coming through.
Okay, great. Okay, wonderful. So at Africa CDC, we use this dashboard for a number of things. And it's, we do say on the dashboard that it is for internal use only, but it is, openly available on the web. Folks can use it. I believe the PERC and the Resolve to Save Lives website also links to it. So it's easily accessible, and we're happy to share the link with you all so you can play around with it. So we internally use this for a lot of decision making, especially with regard to our situational awareness. So we currently hold EOC meetings or Emergency Operations Center meetings twice a week now, still for COVID. We have multiple task force meetings that we also hold for various different topics, for surveillance, for laboratory, for clinical management, infection prevention control. And so we actually use the data that come out of this dashboard to develop our presentations for those various meetings, to also highlight specific countries where we might be seeing increasing trends, and we might want to specifically focus in on a situation in that country. And that's where that visualization that Erin showed 2 slides ago really does help, because you can see over time how cases are increasing, how is the country responding, how does mobility also look, and we also pull in other data sources. So we do have a team that looks at vaccination data. We have a team that is working with a number of regional laboratories and pulling in pathogen genomics data. So we do also look at vaccination coverage rates, and we also look at circulation of the variants of concern. And there are links, if you do go on to the dashboard, there are links to those other resources as well. So general situation awareness. We also produce weekly outbreak briefs, and there's an example on the back right of our latest outbreak brief, and you can get these on the Africa CDC website. So this does give just situational awareness, what's been happening over the last week, what are current numbers. And then we also have weekly press briefs. So the director of Africa CDC holds a press brief every Thursday. And so we use the dashboard to help inform the director of current trends that are happening and what are different things to be aware of and be looking out for. There's a number of reports that we also produce to Africa Union leadership, as well as general reports that we share with the public. And I think you've seen some of these through the PERC project as well. And we've also been able to use some of the data for manuscripts. And so that's an example on the back left of a manuscript that we published last year on an analysis of the first and second waves of COVID across the continent. Next slide. And so, as I mentioned, a lot of the information is really to inform staff, partners, the general public of outbreak trends, and just general situation awareness of what's happening. We do highlight, again, as I mentioned, the countries that we should potentially approach for support. If we do get a chance, if we have a little bit of extra time, we can try to do a live demo of the dashboard. There is a wonderful synopsis table on the main page that shows indicators like percent positivity, as well as different incidence trends for cases, for deaths. And it also does show when the data were last updated. So you can also use that to interpret how recent is the current scenario that you're currently seeing. So, those are different things that we do utilize, especially with percent positivity. We can use some of those indicators to understand what is testing capacity like, if for the PHSMs on the country specific pages, we can understand, is a country scaling up or scaling down PHSM in an appropriate fashion, or is there something else going on that we might want to reach out to the member state to understand the situation a bit better. One thing to also keep in mind is that Oxford's data doesn't get updated as much in real time as we would like. So when we do give specific country-specific reports, we also use, and I know our colleague mentioned EIOS, so we do have routine media scanning that we do every single day. So we are able to pull out country-specific media reports to also augment some of the information that we share. And it also goes into inform a lot of our policy briefs as well as our position statements. Next slide. And so now this piece in particular, and Erin, I know you pulled this in from one of the PERC reports. So this is actually pulled in from the opinion polls that were part of that project. And so for the opinion poll data, when these were actively being conducted, we also used this to understand what the general public was doing, what behaviors were. So we could use that information to also help inform some of our risk communication and what maybe we should be reaching out to member states to be saying or encouraging. Right now, we do utilize the trends within the dashboard to try to help inform what PHSM are being put in place. And then also the vaccination outcomes, but we don't have more recent opinion polls to really help with these trends, but they were very, very helpful when we did have them, especially to understand what the general public's feelings were around adherence and acceptability of personal public health and social measures, as well as what countries were also putting in place. And I think that's it, Erin. I think we can take questions that you have, or we can potentially go into a demo if that would be helpful. So just, gear us to whatever direction you'd like us to go. But thank you, everyone.
Thanks so much. Great presentation. I see there's also been some comments in addition to mine saying how great and useful the reports have been. Any questions? Otherwise, it could be great having the dashboard shown if we don't have questions. Just seeing if anybody's got. Yeah, do you want, I don't see any hands up, so maybe that would be great to show us a little bit on the dashboard in the last 5 minutes or so.
Sure. Erin, do you want me to do it, or do you have a preference?
Go for it, either way.
Okay. All right. Give me a second to pull this up. And okay, so hopefully you guys can see my screen okay?
Yeah.
And I can try, let me see if I can make it a bit larger. Not gonna help. Probably not. Okay. But yeah, so basically you can see that the dashboard, if you want information with regard to the methodology, you can go over into this tab over here. And then we also do have a public health and social measure guidance that you are welcome to check out in addition to our hotspot dashboard. And I'll put the link in the chat if it hasn't already been put in there. But this gets updated on a weekly basis, so we're able to see weekly trends. So this is representing the past Epi week, and this gets updated every Sunday night. You can see that there's a huge blip here for the tests, and that's actually representing bulk reporting from one of our member states. I believe it was Mauritania who actually just shared a bunch of testing information. So occasionally we do have blips like this. We try our best to actually go back and smooth that out and make sure that this information is appropriated to the dates when that occurs. But you can see over the time of the pandemic, a number of member states are not reporting as frequently as they were. So, so as time goes on, we're actually losing the usability of the dashboard because of that. But it's still very functional for the vast majority of member states and helpful for us to at least see regional trends. So anyways, the table that I was mentioning, so you can see here, you can sort by country, you can sort by the level that countries are listed at. You can also look at the trends in new cases, the trends in deaths. You can also look at the testing information, and you can see here when the last available information was shared on that. And if you want to go in to look at the situation for a country, South Africa is always my go-to country. So you can go in here, you can see the sources that we go to for the official information and where they share it. So you can click on those for that information. We also have linked in the PERC country briefs. So you can go and see from those opinion polls what information came from those. And then you can see currently what the warning level is based on the indicators that we're monitoring and the level of those indicators. And then you can see the trends that are happening for the particular country for cases, testing, test positivity, deaths, case fatality ratio, And then we've got the PHSM component. And then we also have this little timeline down here so you can see kind of the stringency that's also put in place, broken down by the different types of public health and social measures. And then if you want more information, you can click on these little guys and it tells you what PHSM changes happened at that particular point in time. Any questions on this? And let me go ahead and put this in the chat.
That's great, Steph. Thanks so much.
Yeah, you're welcome.
Yeah, they've been really accessible. Maybe just one other plug as well for the reports. The reports are even available in PowerPoint, and everything's available in French and English, which has also been hugely helpful working in French-speaking countries. So yeah, it's also been great.
Yeah, and most of the reports should be either, they should be available all in English, obviously, in French, but given the AU languages, we also put them, some of them in Arabic, as well as I believe Portuguese. So depending on the member state and their common language.
That's fantastic. Ruby, yes, and John and Ruby. Ruby.
Oh, John can go first.
Oh, it's just a quick question. It's a really nice dashboard. I'm just wondering, the color coding of the countries, is that automatically done? And how do you, if so, how do you code that? Or is that done by a human? And if so, how regularly is that looked at?
So I'm going to defer to Erin for this one.
Yeah, I might share screen just to walk you through it. Give me just a second here. So this was like the biggest challenge of the project. And the reason why is because the quality and especially the completeness of COVID case finding across African Union member states is incredibly variable. You have South Africa, which is quite good at reporting their COVID cases. You have other countries where testing capacity and is much lower. So what we've done is we've put together these 3 different indicators looking at what we call the test case ratio adjusted incidence, test positivity, and then trend in incidence. Test positivity is pretty straightforward. Incidence trend is pretty straightforward. This indicator is complicated. It's basically we're taking the incidence rate in each country, but then we're factoring in the test positivity, assuming that if a country has a high test positivity, it's a sign that they're undercounting their cases. The long answer to how we do it, so then we take the average of each of those 3 indicators, and that's what's presented on the dashboard. I would say that it errs in the side of placing countries at a higher level, which is intentional. We'd rather have kind of false alarms where Africa CDC staff open up a country's data set, look at the data and realize, oh, it's just a blip of a 1 week increase in cases. You know, maybe they went from 20 to 40 cases and that's causing a spike in the alert level for that country. But anyway, the long version is all on this methods page, explaining how we take, for example, this is the test case adjusted incidence. We take the incidence rate and then we multiply it by essentially the inverse of the test positivity to get this adjusted rate. And how the levels are set based on these indicators is in this table here. So I think that's the short answer to what could probably be its own 10 or 15-minute presentation. That was, yeah, a couple weeks of work just trying to get something that's useful. It's definitely imperfect, but I think we found something that's useful. Rudy, did you have a question?
That's great. Thanks, Aaron. I think we're going to end the call now. Thank you so much for 2 fantastic presentations, and I hope it's whetted everyone's appetites for part 2, which will happen on June the 10th. And that session will really try to explore statistical methods and modeling methods for analysing the effect of public health and social measures on COVID. So we'll have presentations from the London School of Hygiene and Tropical Medicine, Imperial College, and North Carolina State Health Department. So looking forward to that. We'll send out a teaser early next week. Thanks for your attendance.